Namaskar. Greetings from Heart Care Foundation of India and Med Talks. I am Dr. K.K. Aggarwal, and you are watching 7 p.m. Med Talks with Dr. K.K. Aggarwal, a daily show in social media viewed by thousands of people every day. In this COVID edition, 11th episode, we will be talking about another subject which deals with reduction of fear in the mind of the people, and which clarifies that mortality is an exception and recovery is the rule in COVID-19. Before we introduce the subject, let's have the headlines of the day. India records the biggest surge in fresh COVID-19 cases on Wednesday because of 10,000 people in Andhra Pradesh expected. Every state, every city has to show a surge. The Delhi CM Arvind Kejriwal announces delinking of hotels with the hospitals. That means Delhi is under control. The Union Health Ministry has asked DCGI to ensure equitable distribution of anti-COVID-19 drugs, and that is remdesivir and tocilizumab. Jim's Yoga Institute, good news, may open from 5th of August. And if they opens, maybe we start expecting for cinema halls. Serum Institute has been asked to revise protocol for phase 2 and phase 3 trials of Oxford COVID-19 vaccine by the DCGI. Let's go for the topic of the day. We have large segment of the society having diabetes. India is the diabetic capital, and COVID-19 has created a fear in the mind of the people. There are 10 crore diabetics. 10 lakh diabetics die every year because of non-COVID illness. Has this COVID-19 reduced overall mortality in diabetes, or it has increased, added to the existing mortality in diabetic? That's the subject of the day. And I have an expert with me. Let me introduce that expert, Dr. Banshi Sabu. He is the chief diabetologist and the chairman of Diabetic Care and Hormone Clinic at Ahmedabad, Gujarat. He is the president of Research Society of Study of Diabetes in India. He has been honored with many fellowships like American College of Endocrinology, American College of Physicians, International College of Nutrition, and Royal College of Physicians. He is the Honorary Secretary of Diabetes in Asia Study Group and Honorary Secretary of Diabetes India. He is also the founder of NGO Diabetes Care India and India Suite Registry Project. Welcome to our show, Banshiji.
Thank you.
Banshiji basically means Bansuri. When you talk about Banshi, Bansuri means Bansuri. And when you talk about Bansuri, you remember Lord Krishna. And Bansuri is a hollow wood. The word hollow wood means that if you're having a wood, it is called Besuri. And when you create the wood and to make it hollow, it becomes Bansuri, means Madhurta, means love, means unconditional love. So therefore, and in a body, it indicates a egoless state of mind. If you take the ego out, you develop Madhurta and sweet. Therefore, in diabetes, we say, Bansi bajao, yani ke meetha bolo, kadwa khao. That's what diabetes is. And probably that's the reason his father and his parents decided him to become a diabetologist, because the word Bansuri and Banshi means that meetha bolo, kadwa khao. And if you follow that, you may not end up in developing a diabetes with that. So, Dr. Banshi, because the topic is diabetes and COVID, and there is a fear amongst the society that COVID, if it develops among diabetics, they're going to die. The mortality will be very, very, very high. Our emphasis today has to be that how to reduce mortality in patients with diabetes.
So first of all, sir, thanks for giving me an opportunity, and it's really my pleasure to be with you in this Med Talk show. The first thing which we are saying that as diabetic patients having a lot of fear because of this COVID, and every day they are listening that the persons who is having uncontrolled diabetes, he is at more risk of developing complications of COVID, and whether it will increase the mortality or not, that's a major problem with the society. So first, very important thing is, as we know that two-thirds of our diabetic patients are not keeping their good sugar control. And that data, as you are rightly saying, that we have 10 crores of the diabetes. But the worst part is 5 crores of them, 50% of them, they don't know whether they are diabetes or not. So they are not worried that they are diabetes or not. And another two-thirds of that, out of those 5 crores, they are not controlled with the sugar. Now, the person who developed COVID infection, and if he is having a diabetes, it is one of the important major comorbidity for a person who is having COVID infection. Yes, there is a definite increased risk of hospitalization, increased risk of all complication which one may have, the COVID complication with the person who is having diabetes, hypertension, cardiac disease, obesity, malignancy, or CKD. But what we had seen over a period of time in last 2-3 months, initially what we were seeing, there was more mortality and more requirement of ventilator support or ICU care. But over a period of time, even person with diabetes also who are getting COVID infection, now what we are seeing that mortality is decreasing. It's not just because it is, I think, the early diagnosis, right time treatment, which we have starting now the patient with that, and mild to moderate infection. Now many of these patients, they don't require even hospitalization also. At the same time, there are two varieties of patients who are there now we are seeing. 50% of them are now very, very, they had become very regular in their lifestyle because they started realizing that diabetes itself is one of the important risk factor for them to have an infection. If they have an infection, they will have more problem. So they had become very regular. There, we are even doing a telemedicine consultation, and what we are seeing, their sugars are relatively well controlled, and they are trying their level best as far as their diet is concerned, and they are trying to get the best treatment even on telephones. But other 50% of the patients, they are not so regular, neither in their diet as well as nor in their medications, and that's the reason their sugars are not well controlled. So what my message to all my uh, persons who are having diabetes, they should have a tight glycemic control without getting hypoglycemia, and diet control is very, very important. Some of Indian patients, they feel that they may take half a tablet extra and they may keep their sugar good control even if their diet is not good control. Ek rasgulla extra खा के आधी गोली और extra खा लेंगे, is it okay? That type of, the person's having a in their mind the idea that they may take extra medicine. So definitely diabetes is an important comorbidity in the persons who develop the COVID infection. It increases the risk of hospitalization, not only hospitalization, ICU admission, as well as even ventilatory support, and even it increases the mortality. The person with diabetes, with CKD and other complications have more chances of complications. But during last 2-3 months, what we are seeing now, the slowly, because of early detection and timely treatment, we are getting better control of diabetes and better in-hospital hyperglycemia control also, which reduces the mortality too.
So I will ask some quick short questions. Number one is that do you think that because of the lockdown and in the last 4 months, the pooled average A1C has reduced amongst the people? That means people are, because of kada, bitter, astringent food, because of relaxation, less stress, and they are more careful about their diabetes, that more number of people are controlled than ever in the history of India.
Sir, there are 3 papers which were published in last 3 months. One paper from Kolkata group, they had shown that their patient sugar is averagely increased by 2%. There is a one paper from Chennai group Dr. Mohan had published, which he had shown in his paper there is a average reduction of A1C is 1% in some of the patients. We have not published our data, but what I had seen, those patients who are having their A1C who had come to my clinic in month of Feb and March, their average A1C, the 300 patients, and now we are repeating there in July and August. And what we had seen, if you see the 50% of the patient, as I told you, they have become even better control. So those patients who are having even their 8.5 or 9, they are at better. But 50% of the patients, they had not improved. So maybe not just because of CARDA and all these things, unless you understand that diabetes is a major issue and they start taking care of their diet, and at the same time they become more compliant on the medicines, and they are continuously talking to their doctor or on telemedicine or face-to-face consultation. If they understand properly, then many of the patients, yes, definitely the sugar is getting good control.
Second is hydroxychloroquine is an anti-diabetic drug.
But hydroxychloroquine is not taken by all the patients. I mean, yes, HCQ is anti-diabetic.
I agree. But what I'm trying to say is those people who are given hydroxychloroquine and they are diabetics, if they are taking preventive, do you feel that more chances of hypoglycemia if they add hydroglycine?
Because it decreases A1C around 0.4, and we know that HCQ is an officially ICMR approved drug in India, DCGI approved drug as an anti-diabetic also. We are using in some of the patients in diabetes also who have a rheumatological manifestation. So along with as an anti-diabetic add-on therapy also as a third and fourth line agent. And we had seen in the patients it can lead to hypoglycemia if they are on sulfonylurea, they are on insulin, because it reduces average the HbA1c of around 0.4 to 0.6 depending on the what baseline HbA1c they have.
So today we know that on day 3, day 4, day 5, day 6, if you pick up exertional hypoxia, that means on 6-minute walk test, if your oxygen falls by 5 points, you know you have a happy hypoxia, you know that you have underlying pneumonia with smaller clot formation. And we know the drug of choice today is steroid. Now, if a diabetic patient is being given steroid, how much insulin I do adjust for him? So if I'm giving 40 milligram or 40 milligram of steroid or 6 milligram of dexamethasone, well, is there any formula for him to increase the number of units?
It has to be very individualized. There cannot be a one formula. There cannot be a one therapy for everyone. Each and every patient, they differ differently as far as their sugar level are increased. If patient is very well controlled diabetes and he is already on molecule which are not sulfonylurea or insulin, he is not long standing patient of diabetes. If he is given a steroid dose, still the post meal glucose is to increase and he has to be under control. And what we do is for their post meal glucose to get control, one is diet. We have alpha glucosidase inhibitor and glenites, which are short acting sulfonylurea. But some of the patients require short acting insulin also before meals. If patient is in hospital, he is already on a long-standing diabetic patient to whom we are giving IV steroid, and what we had seen, their sugar levels increase too much, and then we start these patients on IV insulin also, which is a continuous insulin. At the same time, these patients are to be monitored every 2 to 3 hours, and definitely pre and post meal if patient is taking orally also, and their sugar or post meal sugar are very, very high. You cannot control these patients on premix insulin because these patients will develop otherwise fasting hypoglycemia. It's a post-meal daytime hyperglycemia, not nighttime. Sugar will not increase. So this is a major difference, and these patients require a steroid-induced hyperglycemia, require very tight glycemic monitoring along with correction dose of insulin.
Most of the diabetics will require a statin and a aspirin. Do you feel that every diabetic on day 1, if they don't, should be on aspirin and statin, and on day 3, if they develop hypoxia, then we shift it to low molecular weight heparin and continue the atorvastatin? If the patient is not on aspirin and statin.
So if patient is not on, I would like to put the patients on statin definitely. Patients also on aspirin, because the high-risk patient who have a multiple risk factor for cardiovascular disease, as we give to all our diabetic patients who have multiple risk factor to statin also. Otherwise, all diabetic patients are moderately high risk, but if they are multiple risk factors, then we give them statin and aspirin also. If they develop hypoxia and we suspect that D-dimer is increasing, we put them on a low molecular weight heparin also.
There are patients who develop non-pulmonary COVID. At least 30% of them, they have either a left eye conjunctivitis, they have loss of smell, loss of taste, or they have a GI involvement. These are the people who do not end up into a pulmonary COVID, even if they develop a very mild pulmonary COVID. Very few of them will develop happy hypoxia. Do you feel these diabetics require no change? Just they continue with their good level of control?
Yes, so they have to continue with the good level of control, whatever the medication. Even for the patients who develop even the lung involvement also with a mild infection, sometimes we continue with the same treatment unless they develop hyperglycemia, unless they develop a patient with a severe condition or a happy hypoxia, they require steroid, then the doses are to be changed. Those patients where non-pulmonary involvement of COVID, we don't change their anti-diabetic management.
I come back to specific drugs, metformin, as far as because most of the patients are on metformin. In a non-happy hypoxia patient, do we modify the dose?
Continue. With
Continue.
hypoxia, we have to reduce or
Yes,
stop.
or stop. So if you develop happy hypoxia, then you stop and you shift to insulin. In any way, you may add up into an insulin. What about Dp4 inhibitors?
So the Dp4 inhibitor, if you had seen, I mean, there are multiple papers, even the metformin and Dp4 inhibitor, both were found to be good in the patients with the COVID in the up to mild to moderate condition. But in severe condition, we stop. But Dp4 is still we continue. We must discontinue the metformin. Once the person develop hypoxia, we continue the Dp4 till persons in either in ICU where we have to give the continue IV insulin therapy. Till that we continue with the patients with DPP4.
SGLT2 inhibitors.
SGLT2 also, there is a one trial is rather going on with the persons who are having COVID with the DARE, which is a dapagliflozin in the patients who are in hospital with COVID infection. But at present, even our RSSDA nationally also we had put the guideline because who are on SGLT2 and getting hospitalized. Normally, we stop it because it can lead to hypotension. There is a more diuresis, and these patients may develop more complication because of genital and urinary tract infection also. So we stop it.
So can I summarize that patients who are at home, mild to moderate, non-oxygen dependent, they are on home treatment, home isolation, just continue your diabetic management. And if it is as before, this virus will come and go. You won't even know about it. The diabetic has not complicated you. If you need admission, whether you are hypertensive, diabetic, or anybody else, anything else, you need a insulin management. You will be shifted to insulin and treated accordingly. The only thing we'll add is in a hospitalization, you will need insulin, but in a non-hospitalized patient, you continue your treatment as it is. Am I correct?
Absolutely, sir. And we have an in-hospital hyperglycemia guideline also, how these patients are to be treated and what we should do, which medicine we should stop and how we should start the insulin. If patient is taking orally, we give them basal bolus. And if patient is on the ventilatory care, we give the patients on IV insulin. If patient is on steroid, we give them on IV insulin. So there is a definite guideline for that also.
So we have definitive guidelines. We'll talk about these guidelines much more in the coming section. Let's have a short break.
Thank you, sir.
You are watching Med Talks with Dr. K.K. Aggarwal, an evening 7 p.m. show, and we are discussing COVID-19 and diabetes. Every diabetic is having a fear that the people will come back and say, oh my God, my parents are diabetic, my grandparents are diabetic, we are very much afraid. The answer is no. Prevent COVID-19 if you can. And if you can't, so what? A person is diabetic. We carry on with our discussion. Our guest is Dr. Banshi Sabu, an expert in diabetology, practicing at Ahmedabad. So before the break, we were talking about diabetics at a home care and then diabetics in the hospital. Our discussion was basically on type 2 diabetics. We have a segment of the society who are type 1 diabetics. Do we have any new policy for that, Dr. Banshi? Type
Yes.
1 diabetics.
So for type 1 diabetic patients, now if you see these are in India, we have two varieties of patients type 1. The pediatric group, those who have type 1 diabetic patients below the age of 20 or 18. So these are young diabetic patients. And if you see the data from all over the world, the young diabetic, because of the young children, those who develop the COVID also, they don't get the complication. Even their sugars are not very good control. There was also one more paper which was published, Dr. K.K. Aggarwal, in pediatric diabetes, and they had shown because type 1 diabetic patients have it is a very typical because it's a beta cell destruction. It's an autoimmune beta cell destruction. And probably this autoimmunity, which is there in type 1 diabetic patients, they develop less complication because of COVID infection. Also, this paper, which was published from the Germany, it was in a pediatric diabetes group. But those who are type 1 since long, so I mean, somebody who is having type 1 diabetes since last 40 years or 50 years, he may have a higher risk of developing complication because of probably endothelial dysfunction. Last 40 years of diabetes, last 60 years of diabetes, and somebody is now at the age of 65 or 70, and he's having diabetes of more than 50 years because he was type 1 at the age of 15 when he had developed his diabetes. So because of this long duration of diabetes, a endothelial dysfunction, and then the complication or chances of complications are high. But for young diabetics who are even type 1 diabetes, the chances of COVID complications are less in compared to other populations. So type 1 diabetes is not in young children is not considered a very strong comorbid condition, even it is uncontrolled.
So type 1 or type 2, elderly, type 1, type 2, irrespective of age, if your diabetes is well under control, don't worry about COVID.
Exactly.
Let it pass off. I come back to three more special situations. One is a pregnancy. And second situation basically is, let's first go to the pregnancy. What changes it requires in pregnancy?
So if somebody is already pre-existing diabetes and having a pregnancy, it means pre-gestational diabetes. A type 1, if she is having a type 1 and then she is becoming pregnant, then these patients require more tighter glycemic control. Because if in during pregnancy, there is a lot of glycemic variability, chances of premature or chances of even complete abortions are very high. So in a type 1 diabetic patients, we make sure that patients should not have a lot of glycemic variability. The person with a pre-gestational diabetes of a type 2, young female who are already type 2 and then they become pregnant, they are also started with the insulin therapy, and only other anti-diabetic molecule which can be continued is metformin in these persons. The who is first time detected diabetes during pregnancy, we call them GDM, that is gestational diabetes, and these are the patients for 50% of the time their sugar can be very well controlled with the diet control, and some patients may require only metformin, and in the later stage they may require the insulin therapy also. First we start with the only bolus insulin and then basal. Now during this COVID era, many of them, they become, because of this already they have a diabetes or they are first time developing GDM, they become very much tense because of a lot of anxiety, what will happen, how the delivery, one side they have a diabetes also. But what we have done is, all my patients and all those gynecologists who are connected with us and all our patients whom we are seeing them is a GDM or the type 1 who are becoming pregnant, we have done a teleconsultation, and almost every week, because they have to do their sugar report very tight to get very tight control, they have to monitor at least once in a day or twice in a day, and every week we get their data and we see if their sugar are very well controlled. We don't call to the patients face to face, and it is everything is done on video consultation, on teleconsultation, and they have not to worry as far as COVID is concerned or as far as this GDM or sugar is concerned.
So if you have asthma, if you have diabetes, if you have COPD, if you have hypertension, if you have heart failure, Whatever disease you have, it is well controlled. If it is well controlled, don't worry about COVID. Most
Perfect.
important thing is to wake up, control your disease, whichever you have now. I come back to one more question, and that is, can COVID-19 precipitate diabetes?
Yes, sir. So there is a COVID hyperglycemia. There are two different type of patients who are first time detected hyperglycemia or glucose level after the COVID infection. Now there is a two possibility, and we get it by HbA1c. If A1c is already high, as I told you, 50% of our diabetic patients, they don't know whether they are diabetes or not. And first time they are detected because COVID infection, there is a now opportunity. The sugar is being checked out, and they found to be very high, and they have already a pre-existing diabetes. So we will say it's a unmasking. You are already having a diabetes, or the sugar was already high and it was first time detected. But there is a one more condition where A1c is normal and still they may develop COVID hyperglycemia. Again, it could be because of stress-induced hyperglycemia. In hospital, we had seen there are new detected hyperglycemia in the patients of diabetes. I mean, in patients who are getting hospitalized. But there is one more condition. It may, COVID itself can also lead to beta cell dysfunction. And there are some papers which are published, and that is new COVID hyperglycemia. We can call it a new entity. It can be a COVID hyperglycemia. We don't know what will be long-term effect of this, whether it will go away after the completely infection will go, whether it will remain in some form, will it be converted as a autoimmune diabetes, will they have type 1 diabetes. So we are seeing some of the patients who are discharged, first time detected as a COVID hyperglycemia. Just now we have treated them, we got their C peptide, we have done their autoantibody test also. We had not found autoantibody positivity increase in our patients, because I had seen almost 6 or 7 patients who are first time detected as a COVID hyperglycemia where their A1C was normal, but we had not seen their autoantibody is positive or C peptide is low. So they are not converting in type 1, but we are following them continuously. And at present, we are treating them as a type 2 diabetic patients, and some of the patients who are require even insulin also.
We do know that COVID-19 causes inflammation. We do know that it causes subacute thyroiditis. It can cause right iliac fossa inflammation. It can cause inflammation, tonsillitis, serous otitis media, anything it can cause. It's a mysterious virus. It is unpredictable. It can precipitate diabetes. Therefore, if you find a patient who has recent hyperglycemia, which is persistent, watch for a development of diabetes. So do a monthly HbA1c to see whether the A1c is now rising or not. If the A1c keep on rising and get established, you know that this patient's diabetes has been a new onset diabetes which has been precipitated. I come back to the last question before I pick up few questions from the audience who is there. There are a large number of people who are present, who are watching this program. I think I talk about is we know that all diabetics need pneumonia vaccine, they need flu vaccine. And when COVID vaccine comes, obviously they will need a COVID vaccine also. But what about this BCG, MMR people are talking about? Do you feel that diabetics can be given either a recombinant BCG or a live BCG vaccine, earlier BCG vaccine, and what about MMR? What about your personal thoughts into this? There are no
So
ICMR recommendation. There are no
at
recommendations.
present, we don't have any recommendation. That's number one. The BCG vaccine, those in India, many of us have already BCG vaccine is already been done. For MMR, my personal view is that yes, it can be given because the rubella and mumps have the 30% similarity with uh, the COVID also. So probably it can protect. But till we get the guideline from the ICMR or even international guideline, I don't think I can recommend to my patient. But during this period of time also, what I have done is, as we are recommending adult vaccination, where influenza vaccination and pneumococcal vaccination, which we normally recommend to our diabetic patients, which we continue to recommend. And what we had seen in last 3 months, many of our patients, they asked that, yes, sir, I want to take the vaccination, at least for flu vaccination, which you usually used to tell us, and even pneumococcal vaccine also. And many of our patients have taken the vaccine.
This is Atul Mule. One of my friends stopped taking metformin and started Ayush tablet. He suffered a lot as he didn't measure sugar and did self-medication on diabetic foot. Doctor cut down his 4 fingers due to his self-medication. That's very clear. Please do not do self-treatment. And good evening. I'm Rahul. I'm suffering fever from last 10 days, and now I face major joint pain. Rahul Patil ji, joint pain usually is absent in COVID. Look for a doctor. If it is a COVID joint, it will be very, very rare. We call them as this type of a joint involvement, hoarseness of voice, and mediastinal lymphadenopathy, pleural effusion, and a pericardial effusion predominantly rules out COVID infection. And then there is my father. This is the last question I'm taking. My father is in Greece. He is in a ship and he was tested corona positive, but the ship company aren't giving proper medication. Giriji, most of the people require actually no treatment. Most of the people will recover. So whatever their government protocol is, they will follow. There's nothing we can interfere from India and telling the Greece authorities what to do, what not to do. Unless he has a pneumonia, then also there are standard protocols available. I would like to have Dr. Banshi Sabu to give a final words about his messages.
So first and very important, sir, as you rightly said, that first, all diabetics should not worry about it, that COVID will increase their mortality or they will die. Second thing, they must control their sugar. Even this during COVID time, I think this is an opportunity. They should understand that diabetic patients have a immunocompromised condition. They may have lot of infection. So it is the best time they should control their sugar. For future also, a tight glycemic control will definitely improve their immunity. The third thing, they should not do like stopping the metformin and taking other Ayurvedic medications or some other medication. That they should not do. They should try to achieve a tight glycemic control without getting hypoglycemia, and diet and exercise is very, very important. So lifestyle modification in a diabetic person is extremely important. Even who are not diabetic and who are at the risk of developing diabetes and having metabolic syndrome, they also must follow a lifestyle modification to prevent diabetes. That is very, very important. And we can prevent diabetes by doing a good lifestyle modification. And I think Dr. K.K. Aggarwal gives every day some tips which can prevent not only the COVID, but also diabetes and cardiovascular disease in our society.
Let me end up by saying that buy a SpO2 monitor. All diabetics should walk every day in the morning. Just check 6-minute walk distance. If you walk for 6 minutes and if your SpO2 doesn't fall, if your walk distance is more than 500 meters, you are cardiac fit, you're fit to develop, you're fit to tolerate the COVID-19. And also, just check the temperature also. If you have a temperature on exertion, maybe you are having a post-COVID phenomena. And never forget that even if you are a diabetic or not, if you lose the taste of the sweet or the smell of the laddu, you may be having a loss of smell and loss of taste, which may be a sign of that you are having a absolutely non-dangerous COVID-19. So wish to God that if you get a COVID-19, you get a COVID-19 with a loss of smell, loss of taste, for two reasons. The disease will be mild. It is not going to convert into a pulmonary pneumonia. And those 14 days or 2 months or 1 month, the loss of smell and loss of taste last. It will be an opportunity for you to control your diabetes forever. That's all for today. Let's thank Dr. Banshi Sabu to be here, and all our listeners and viewers. Thank you very much for joining. We'll be back tomorrow with a 7 p.m. show with another topic. Stay tuned. Namaskar.
Thank you.